Good evening, and a very happy good evening to all of you. And let's see if we can get everything to all sync up here. Yes, indeed. Happy good evening to everyone. It is 5 o'clock on the Gulf Coast, which means 6 o'clock on the East Coast, four in the mountains, and three on the West Coast. And it is time for Fertility with Fink and Friends. I am Fink. You are Friends, and it is great to see all my friends here this evening. This is the place where you are supposed to be every single Tuesday at this time, 5 o'clock Central Time, where we can talk about all those things that are important to us. That's the stuff about making a family. That's the stuff about getting pregnant. That's the stuff all about women's health and everything that you have on your mind tonight. I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida. We also have offices in Panama City and in Mobile, Alabama. And I also work with the Missouri Center for Reproductive Medicine, MCRM, in St. Louis, and their office in Tulsa as well. And wherever you are tonight, my thoughts are with you. Hello to all my friends. Dee, good evening to you. You, I believe, you were the number one there, Dee. Thank you for being the first to join in here tonight. We've got Purple Haze, my friend Logan, the therapist in Northwest Arkansas. Good evening, and thank you for being here. Marlena is with us, bienvenida, and I've got my beautiful mother and father in Mobile, Alabama, the Bama Gal and pal, I guess we can say, watching us this evening, and glad everyone is well and healthy tonight. That's my Instagram feed here, and that's Randy Fink MD. This is New Life Fertility's Instagram right here, and Morgan is here with us tonight. Good evening, Morgan. We've also have Facebook, a couple of different Facebooks, New Life Fertility and MCRM. We've got LinkedIn, we've got YouTube. We've got the First Fertility Network, of which both MCRM and New Life Fertility are proud members. So what's on your mind tonight, folks? Hi, Tara. Good to see you here as well. What are you thinking about? What can I answer for you to try to make things easier? You know what? Let me start off by talking a little bit about egg freezing. Egg freezing, we started off the program last week talking about a little bit about egg freezing, and I got a couple of follow-up questions, and that was, well, what is when is the best time to think about egg freezing? And it used to be that if you went to the OBGYN, they would say, you don't really have to worry about egg freezing until you turn 40. By 40, it's really, it's much later than we really want for it to be. So the whole point of egg freezing is that you can basically buy yourself a fertility insurance policy. So the younger you are, when you retrieve and save your eggs, the greater the probability that those eggs will be normal and ultimately have the capacity to be able to make you a normal embryo. And of course, when I say normal, we need a normal embryo in order for that embryo to be able to stick inside the uterus. And it's not that an abnormal egg gives you an abnormal embryo that gives you an abnormal baby, right? The biggest issue is that if the egg itself is not chromosomally normal, if the embryo is not chromosomally normal, then it just doesn't stick. You just don't get a positive pregnancy test. So the earlier you are, the younger you are when you retrieve those eggs, the greater the probability that those eggs will be chromosomally normal, and the greater the probability that they will be of use to you. The whole point of doing it is doing it so that you have the options later on to use that if you need it. Now, just because you have those eggs doesn't mean that you have to use them. You absolutely can still get pregnant in the normal way. But let's say that, 10, 15 years goes by and maybe you don't have the right partner, or you're reaching an age where you're just ready to kind of have that baby. Or let's say you do have that right partner and you're trying and it's not working, then you've got the eggs from a much younger age, which gives you really a greater probability that they're going to be normal and be able to get you a pregnancy. So that's the whole point of egg freezing, as early as you can. That's my recommendation to you. Hi, Heather. Nice to see you. Hi, Heather K. And Morgan asks us, I plan to do PGTM testing. Are you able to explain how the probe works? Yes, indeed. And a hi also to Mama Fran here this evening over on the New Life Instagram side there. So PGT, of course, stands for pre-implantation genetic testing. So the most common type of PGT we do is known as PGTA, and that's pre-implantation genetic testing for aneuploidy. And aneuploidy means looking for abnormal chromosomes. And so what happens is that we grow your embryo. Sperm comes together with egg. We put the sperm inside the egg, and that creates an embryo. The embryo, we then grow that embryo to the day 5 mark, which is what's known as a blastocyst. And the reason that we go to day 5 is because we know that every egg is not going to be normal, right? They're just not. Every egg won't be normal. And so if we grow to the day 5 mark, then we know that what we're doing is we're letting nature help us to select that first group of embryos that has the higher probability of being normal. So if it's not a normal egg, which creates not a normal embryo, then the embryo stops growing. If it makes it to the day 5 stage, the blastocyst stage, we know it just has a higher probability of being normal. So what they do then is the embryo looks like this. The baby parts here are on the inside. And what they do is they take a few cells from the outside part of the embryo here. And that's the part, it's called the trophectoderm. It's called a trophectoderm biopsy. And basically that's the part that's going to become the placenta. And so we take a few cells from what becomes the placenta, and we can actually test the chromosomes in that embryo, right? So that's PGTA. And the report that we get back there, Morgan, says that it is either normal chromosomes, like 23 pairs, 46 chromosomes with a sex chromosome, XX or XY. And that tells you, is this a euploid, meaning normal chromosome embryo, versus aneuploid, which means abnormal chromosomes. And we look for those chromosomally normal embryos because that embryo has the highest probability of being able to get us a baby. And that's about a 65% chance of pregnancy with that one embryo. Now, PGTM is where we are looking for a single gene mutation. So let's say, for instance, that both you and your partner are carriers for, let's just say cystic fibrosis, because that's a fairly common one. Let's say that you're both carriers for cystic fibrosis. Well, if you're both carriers of that same, in this case, autosomal recessive disease, then you have a 1 in 4 chance of having an affected baby. And so we can say, well, gosh, if we do PGTM, then we can identify the embryos that do not carry the disease. And thus, when we choose the embryo for transfer, we're choosing an embryo that we know is unaffected by the disease that you and your partner are carriers for. Now, this carrier status thing, I always tell people, what the terms I use is that we have a very colorful genome. And by that, we are, many of us are carriers for all manner of different genetic diseases. And really, in most cases, they have no consequence unless the partner is a carrier of the same thing. And if it turns out the partner is a carrier of the same thing, then we've got this 1 in 4 chance of having the affected baby. So the time to find out about that is, of course, before you get pregnant. Another common one we see is the BRCA gene. The BRCA gene. Carriers of the BRCA1 or BRCA2 gene have a significant increased risk, like a 90% lifetime risk of breast cancer, a 50% lifetime risk of ovarian cancer. In the male offspring, there's an increased risk for breast cancer and prostate cancer. Now, the BRCA gene is passed on in a different manner. It's an autosomal dominant type transmission. But if you are a carrier and you want to know that your baby is not going to be affected by the BRCA gene, we can also do PGTM for BRCA testing. So basically, what they do in all these cases is they get some genetic material, typically from you and from your partner. And when we get the genetic material from both partners through, I imagine through computing, the power of modern computers, we're able to predict what the gene sequence is going to look like in the offspring. And that's what's meant by creating the probe. They're able to determine what that gene sequence for whatever the disease is going to look like in your embryo. It's fascinating stuff, really. And then they take that probe, as we call it, that sequence, and they search for that gene sequence in each of the embryos, in the biopsy from each of the embryos that was created. And that's how you know, is that embryo going to be a carrier? Is that embryo going to be affected, or is that embryo not going to have anything to do with it at all? So what's meant by making the probe is that they take your collective genetics and model what the gene sequence will look like in the offspring, so that then they can test those individual embryo biopsies to see which one will be affected. And that's how you have a baby that doesn't have your disease. It's really, really fascinating stuff. So that's PGTM. Morgan, and I hope I answered the question. And hi to Sheila. Nice to see you here this evening as well. Let's see. We got a bunch of folks here. Oh, it looks like we have the Brainards in Key Largo or maybe in Connecticut here. Nice to see you guys if you are indeed still on the program here. Elena says good evening, and a special good evening to you, Elena. Thank you for being here. Dee says, I made an appointment to see you next month, and I was advised that I would have to travel to Pensacola for all testing. No, that is not actually the case. The testing can be done. So I am based in Pensacola, Florida, here as my main kind of gig. I also work, in St. Louis and in Tulsa. But we do see patients from all over the United States, and testing can be done. The blood tests can be done really at any lab. The ultrasounds can be done at any place. Now, if you're doing treatment with us, those treatments do take place here. But yes, we do see patients from out of state, out of area, all over this great nation of ours. So I'm flattered, Dee, and I will look forward to seeing you. But yes, you can do your testing and treatment any place you are. Your testing, I should say, any place you are, and your monitoring for treatment as well. We can work out that. Let's see. And I think I saw a question. Tara asked, do you see patients that live out of state? And in following up with that, why, yes, we do. Patients from all over the United States and, in fact, all over the world. Shadia, good evening to you. And Angela Sack, it's my pleasure to see you here. I haven't seen you for a little bit. Hi, Midgie. Good to see you around. Marlena asks, I'm thinking about estrogen use during a medicated FET. For those with endometriosis following suppression. Is that something that you hear concerns about and have to worry about? And the answer is no, you don't have to worry about it, because the whole point of suppressing the estrogen and the other hormones that are supplying endometriosis is so that the inflammatory effect in the uterine lining is turned off. And so you want that to be turned off so that it doesn't have the anti-progesterone effect that happens when you try to put the embryo inside. But you can't get pregnant without estrogen. Let me repeat that. You cannot get pregnant without estrogen. You have to have estrogen. And so using a little bit of estrogen in order to thicken your lining does not more quickly turn back on endometriosis. It's not a problem. You have to use it because otherwise you can't build a lining. Now, sometimes, there's another option with embryo transfer, and that's to do what's known as a modified natural, which is where you make your own estrogen instead of using the pharmacologic estrogen. But the problem is, after suppression, I absolutely positively do not recommend trying to do a natural cycle, because most of the time it just doesn't work, because you even though your suppression is turned, has ended, it has stopped, you're a little sluggish to kind of return back to full on normal hormones. And so most of the time I see modified natural really being unsuccessful. So it's just sort of bedecked with heartache and aggravation. 100% I recommend doing a medicated cycle after suppression. But you don't have to worry that suddenly that estrogen use is going to, flip the endometriosis back on. Typically after suppression, we think that you probably get about 6 months worth of suppression. And that's whether you cycle medicated, whether you cycle naturally, whatever else is really going on in your world. Now, the other thing that kind of goes along with that is that when we talk about suppression, we're usually talking about doing embryo transfers. So there are people that say, well, why can't I, do suppression and then just do timed intercourse? You can, but timed intercourse itself has a really relatively low probability of success in getting people pregnant, especially in the population of people who come in to see me. Now, if you have no fertility issues, then timed intercourse may be a very straightforward thing for you. You may not have any trouble. But doing suppression and then doing timed intercourse, the problem is once you finish the suppression, the clock starts ticking. You got about 6 months of suppression. So most people would choose to do something that's going to give them the highest probability of pregnancy after taking that medication. And that is having made an embryo, which I suggest you do beforehand. Don't do suppression before getting your eggs. Making that embryo and then just putting that embryo inside, because we have really higher than a 65% chance of pregnancy in that first cycle if you're using a euploid embryo for transfer after suppression. So kind of my feeling on that. Lana asks, do we have any idea when urology services will be available? And if you're talking about here for us at New Life Fertility Urology, that will be in about 2 weeks. So if you give us a call, I am happy to give you the referral to the male fertility urologist, who will be starting in about 2 weeks at the University of South Alabama in Mobile, but he will be coming here to work with us. His name is Dr. Nick Diebel, and is a very, very nice man, a very kind man. And one of these evenings, I will have him on as a guest, because this is Fink and Friends. I am Fink. You are friends, and he's a friend too. So he might as well be your friend also, and can answer all your questions about male fertility. So that will be coming soon, but he is starting imminently. I think his first day on the job is about 2 weeks from now. So like I say, if you want to give us a call, I'm happy to forward along that number to you, where you can reach to kind of get things moving on the male side, if it's something that we haven't been able to do otherwise up to this point. Let's see. Lisa is here. Lisa in US, and we've got Kylie and Lam Muher, I believe that says. D says out of state. Yep, and happy to see you. Hi, Sarah and Kylie ask, can taking Medrol instead of prednisone cause PGTA to fail? And the answer would be no. So Medrol is just kind of another way to use a corticosteroid like prednisone. They have the same effect. Typically, Medrol can be given on a shorter term than prednisone. Prednisone is often continued until about 10 weeks of pregnancy, when then it starts to taper off. Now, prednisone is something that is used very commonly in embryo transfers, but if you actually look at what the data says about embryo transfers and when prednisone is important, you'll find that, well, you know what? Actually, the data really is not supportive of corticosteroids for most people. even though, we do use it. So would I expect that using one form of steroid over another would have an effect on a transfer being unsuccessful? I would say no, Kylie. I don't think so. Most of the time, when a euploid embryo doesn't implant, even though we know, or at least we believe, that the chromosomal makeup of that embryo was normal, and the chromosome part, is the most common reason that an embryo doesn't work, because it's just not a normal embryo. When you do PGTA, you are doing that so that you can identify, right, those embryos that are believed to be chromosomally normal, and you get past that whole thing about the chromosomes. So we at least believe that the chromosomes in that embryo are normal, but it's not 100%. It's a 65% probability of pregnancy, which is not 100%. And really, honestly, what that says is that there is a realistic possibility that the embryo doesn't implant for other reasons. There are lots of things that can kind of go wrong with an embryo that can keep it from sticking. Imagine this as, as I tell people, there are millions of little chemical reactions taking place at any given moment in each of us, and certainly even in each of us when we're just a bunch of cells like an embryo. So if one of those little equations goes awry, then we may run into a situation where the embryo just stops growing. And it's an unfortunate thing. It is it's a very hard thing to deal with. It's hard enough to do an embryo transfer and not get that positive pregnancy test. But it's even harder when you have a euploid embryo, because the expectation is generally much higher. Now, for folks who have had 2 euploid transfers that were not successful, I usually suggest that we start looking under different stones to see if we have missed something there, something like endometriosis, which we can test for non-invasively. There's a whole kind of workup that we look at for people just to make sure that things all look good. But not something that you have to do before a basic embryo transfer. I'd say you're fine to go ahead and do it. It is not unusual that the first transfer doesn't work, but by the time you're on embryo number 2, Kylie, then you're looking at pretty close to a 90% probability that you're going to have a pregnancy from that second euploid embryo. But no, I would not think that using a different type of steroid would be a cause of that to fail. Lisa asks, a day 5 euploid embryo equal to 3 weeks of growth in an FET? So a day 5 euploid would be the same as saying, so the day that that embryo is transferred, you would otherwise be 2 weeks and 5 days pregnant. 2 weeks and 5 days pregnant. That's pretty much how that works. Angela, my friend, says, what's the likelihood of a 2-centimeter fibroid being behind hiding a small uterine septum? I had a hysteroscopy and that was found. Well, I would think that if there is if that fibroid is inside the uterine cavity, I would say, well, you know what? That's a realistic possibility, because if it's in the uterine cavity, that distorts the cavity. That may make the way the fundus, the top part of the cavity, looks may be completely off. It might just be wrong, and you miss the fact that there is a little bit of a band of muscle that's sitting in the uterine cavity there. And so, yeah, that's possible. Now, if it is a 2-centimeter fibroid that is just hanging out in the muscle of the uterus, that is to say, an intramural fibroid in the wall of the uterus, then no, I don't think that could have much of a mechanism to really be hiding a septum. Morgan says, thank you so much. Oh, because we answered your question there. If it's a dominant gene mutation, would PGTM give an answer with certainty that our embryo does not have the gene issue? And the answer is yes. That, to the extent that what they call next generation sequencing is able to do that, which has an extremely high sensitivity and specificity. Yep, that mutation PGTM is can tell you that your embryo does not have the gene. Absolutely, because that's kind of the reason that you'd want to do it, right? Yeah, you can feel a pretty confident in that. And hi to Nikki P. Nice to see you here this evening. Let's see what else we got going on here. Shadia says it's almost 8 months now. Holy cow, I did not realize that you had gotten pregnant there and you are having a little girl. I am so proud and so happy to hear this from you. How wonderful. And thank you for everything Shadia says. And that is just great news, boy. So big changes come into your house, diapers and some sleepless nights, but it is really resplendent with joy. And the thing I got to tell you there, my friend, is it becomes, it's hard. It's hard having a new baby in the house. Just enjoy watching your child grow. And anybody, with kids can tell you here, it goes by so fast. It just really, really does. And I've said this before. I've got a 19-year-old now and an 18-year-old and a 14-year-old. And in my mind, I'm still rocking them all to sleep. I'm still feeding them in their high chair and listening to them laugh and seeing them take their first steps and talk in their little baby voices. And gosh, it just, in a heartbeat. A good friend of mine says, you know what, we don't get to rent them for all that long. Then they grow up and they go on, and if you raised them right, then the right thing is that they leave the nest. But it's tough, and I look back on those days, and kind of really wish I could relive them. Everybody always said, "Oh, it goes by so fast," but you don't realize it until you're walking in those shoes. So enjoy every single moment, even the sleepless ones. Even the ones that are full of heartache, even the dirty diapers and the tantrums, all that stuff. It's a gift. It really truly is. And speaking of which, it's the bottom of the hour, so that means it's time for us to kind of do something special that I do every week. If you're just joining, this is the time that we do the 5:30 Fuzzies with Fink. So it's 5:30 here on the Gulf Coast. And it's a hot one out there, by the way. This is the time that we all get together and stand as one community and send out all our positive thoughts, our love, and our positive vibes to everybody out there tonight who needs to hear it. To everyone who is feeling alone, to everyone who is depressed over where they are, to everyone who is anxious over what might happen tomorrow, to everyone who is ruminating on decisions that they made in the past that brought them to today, and worried about how that impacts the future. And whether that is the fertility thing, because fertility is it's the worst roller coaster in the park, as I am fond of saying. It jerks you around, it hurts your neck, it hurts your back, it gives you a concussion, it dumps you upside down and empties your pockets. God only knows that's true. And the problem is, the train's going to pull back in the station, and it's just an uncertainty as to whether you're going to get off of it with a baby. And that's a really hard thing to deal with. This is the time that we can all say as one community, we're going to get through this. And like I said, whether it's fertility, whether it's dealing with school, with a relationship, whether it's dealing with work or just all those troubles, family, things that life throws at us, brighter days are ahead. You are not alone out there. I really do believe that every single person who watches this broadcast, and sometimes I'm blessed to have 200 or 300 people watching, I think that pretty much any one of you would give your right arm to somebody else who is in need, who is experiencing something that you yourself have felt before. So just to know that other people are out there, such an important thing. I close my show every week by saying tomorrow is a new day and it's full of all new adventures. And I mean that with every ounce of who I am. So come tomorrow, do something nice for a stranger. Do something kind for someone, smile at someone unexpected. Just, this is how we change the world. This is how we make the world a happier place, one mind at a time. And I spoke with a really lovely patient just last week who had been through really a bunch of ups and downs in her life. She had dealt with cancer and survived. She dealt with relationship issues and survived. And she realized that every day that we have is a gift. And she told me that as much as she's trying for pregnancy and really an uphill battle, keeping a real positive outlook on it, that despite all those curveballs, tomorrow is a new day, and it's full of all new adventures. And you are an inspiration, my friend, and I thank you for sharing that with me. And for all of you out there, thank you for being a part of the 5:30 Fuzzies with Fink. Send out those good vibes. Send a heart if you would. Push the button so that everybody knows you're a part of it. And if you have a friend who can join us next week, even for 2 minutes at the bottom of the hour, to share some of that love, we can make the world a better place, one mind at a time. And that's the Fuzzies with Fink. Thank you for those hearts there. I appreciate that. Hi, Brittany. Good to see you this evening. Let's see. And Kylie asked, well, there again, I think we're the question about the prednisone versus Medrol. No, I don't think that's so much a thing. Hi, Missy. So significant. I like that. My friend, the Fox up in Minnesota. Good evening, my dear. Great to see you here tonight. Kylie says, miss you at CNY, by the way. I came back for a second baby and you were gone. Yes, I am. I am in Florida now, as you can tell from my tan. Yeah, that was meant to be a joke. But yep, miss you too, Kylie. Thank you for those kind words. Shanna, good evening to you. Angela is okay, now we're back. Sorry about that. We lost a microphone and lost a light there, so it suddenly kind of got a little dark. I think I pulled it out. Sorry about that. Angela, have you heard of a womb leaf? A womb leaf that you use after having uterine scar tissue removal. Well, if I'm not familiar with that terminology, but there is such a thing as one of the concerns we have when we do something inside the uterus, particularly like maybe removing a septum, and I think you are a septum kind of person, if I'm not mistaken. If we do that, then we can leave behind some scar tissue. And so imagine the uterine cavity, kind of looks something like this, and it's what's called a potential space. And so when you put a baby into it, that cavity kind of starts to grow, but as is, it's sitting, kind of collapsed. Right. And so if we go in with a hysteroscope, what we do is camera goes in, we distend the uterus with fluid so that we can see on the inside. And let's say that you have this septum, right? And the septum is this band of muscle here that kind of goes down the middle. And let's say that we treat this septum to make it go away. Well, what you want to make sure is that tissue doesn't, because you've operated on that tissue, that then it doesn't, just like a scar anyplace else, that the top and the bottom layers don't scar down together. So there are different substances and different things that you can put inside the uterine cavity Estrogen is probably the most important hormone that's involved with that. You can use platelet-rich plasma. You can use the balloon that's associated with a Foley catheter that would normally go in the bladder. And I wonder if that womb leaf is one such thing. But basically, it's designed to support both the top and the bottom layers so that they don't stick together, and as they heal, overheal, so that they are becoming one contiguous layer. And that's what we call uterine scar tissue or adhesions. Or synechia, and that creates synechia is the word there, and that creates a situation that's known as Asherman's syndrome. And Asherman's syndrome is when there's scar tissue on the inside of the uterus. So yes, that is a well-recognized thing. Assuming that's what the uterine or what the womb leaf is. A well-recognized thing, and yeah, I would support that. Usually used along with some estrogen in order to keep the top and the bottom layers from creating scar tissue. Looks like Val Gomez is here. Nadia is here this evening. We've got the Meg Johnson. Hello this evening. Ashana. Elena says, "Dear Doctor, we are currently in the embryo development stage. We truly want to thank you and your wonderful team for the kindness and care at every step." Oh my goodness, thank you. Thank you. That is such a nice thing to say. Thank you very, very much. And it is our pleasure. I can't tell you what a pleasure it is to hear happy stories like that. And you know what? This is kind of how that process really works, So the embryo is in development, and every single day I go in and I sing them a song. We want to, make sure that they're feeling attended to. We've got embryologists who read them stories, and there's another who, rocks them in a chair because we think that nurturing is a very important part of the early development. And of course, I'm kidding, but we take great care of those embryos, and really as each day goes by and they're one step closer to being a baby that you hold in your arms, makes it all the more special for us. So typically usually by day 7, after the embryos are created, you will get a final report that tells us how many blastocysts you made, and how many were biopsied if you're doing PGT, and how many were frozen. The PGT process takes anywhere from 2 to 3 weeks generally to get those results back. It's a hard wait, man. I got to tell you, it's a hard wait, waiting to get those results. But hopefully they come back. With some exciting news, and then you go and you plan your embryo transfer. Now, what happens with an embryo transfer? The embryo transfer is the process where you get some estrogen, which builds that uterine lining, and then you get some progesterone, and the progesterone is the part that takes that lining. It starts to compact it. That nice thick, warm, juicy lining is what where a baby wants to implant. So then it has to just kind of get made perfect. That's what the progesterone does. That controls what we'll call your fertile window, that progesterone. So typically it's 120 hours of progesterone plus or minus 3 hours. It's very specific. You do an embryo transfer, and that's done under ultrasound guidance, where we place the embryo. Ultimately, we're looking for that embryo to be about 1.5 centimeters from the very top part of your uterus, and we see that with ultrasound. And with any luck, and with a good embryo, you get a positive pregnancy test usually about a week later. Now, there are some programs who will wait to do that pregnancy test until maybe 10 or 12 days. Either way, or call it, the 2-week wait. They might make you wait for 2 weeks. It's a long wait. It's hard to do that when you are really impatient and waiting to find out what happened. But here's the thing. So we do it about a week, about 7 days. And really by 7 days, what I have to tell you is that a urine pregnancy test may not be positive. by that point. So I always encourage our patients, don't do a urine pregnancy test because it may come back if you're doing a day 7 beta blood test, because it may not be high enough a hormone level for that urine test to be positive. And then you do your pregnancy test, you're heartbroken because it's not positive. And then you drag yourself in because you have to come do a blood test only to then find out it's positive. So don't set yourself up for, there's way too much stress in this whole process. Just ride with it. Don't try to make your own rules because we know how to kind of try to get this done in the least stressful way as possible. But that's kind of what the next steps are after that all important embryo growing time. But for yours, I will go in and sing them a song. How about that? What else is on your mind tonight, folks? My name is Dr. Randy Fink, and this is Fertility with Fink and Friends. I am Fink. You are friends, and I am live tonight from Pensacola, Florida, where I'm a fertility gynecologist at New Life Fertility, also with offices in Mobile and Panama City. And I am also a fertility gynecologist with the Missouri Center for Reproductive Medicine, MCRM, in St. Louis and Tulsa. It is just such a pleasure to always be here with my friends. Every Tuesday night at this time, 5 o'clock Central. And don't forget, at the bottom of the hour is the Fuzzies with Fink, an important piece of your week as you get some positive affirmation from all those people going through the same doggone things that you are. That's what we do here. Hi, Pooey in St. Louis. Good to see you. Lisette, nice to see you here as well. D asks, the embryo glue, is there a way in science to make them stick rather than have them floating? Well, so let's talk about that thing that's called embryo glue. That, my friend, is a gimmick. It is a brand name of something that's called hyaluronic acid, which is part of the chemical substance that is part of the media that an embryo is in when it is transferred. It just happens to be the brand name embryo glue. And it's a really smart thing because they market that out there and everybody thinks, oh my gosh, I've got to have the embryo glue because the glue is what makes it stick. And that is not the case at all. So again, that's just the chemical that's in the media that makes the that is part of the liquid that the embryo is in when it's transferred inside of you. So once that embryo goes in, and if you've had an embryo transfer, you probably know that oftentimes when you look, you get to see a little flash of light, like a little, I call it like your little shooting star. And what that is it's usually, it's a little drop of liquid and an air bubble that we put inside the syringe. The embryo itself is too small to be seen, right? But you can see the little droplet of air, and you can see the little droplet of fluid. And when that goes in, it sort of looks like a little bit of flash so that we can see where it ends up, basically. But the embryo itself kind of floats around inside the uterine cavity. When I say floating, remember, it's not like a swimming pool. It's not like there's like a big area that you could, like putting it into a bottle and that then you could shake it up and it can move all around. Remember, we talked about just a minute ago, the uterus itself is a potential space. It's that flat space with some sponges. Think about the uterine lining, the endometrium, as being a sponge on both the top and the bottom. So the embryo is just kind of moving around a little bit. It's just sort of and again, I started to use the word floating, but it's not floating. It's kind of just, moving around until it finds the best and most comfortable spot for itself. So it's not that it's being glued in one place by embryo glue. It is, again, that's just the liquid that the embryo is packaged in when it's placed inside. And that's the brand name of one of that type of media. So it goes inside. What causes an embryo to implant in one specific place versus another? It often has something to do with the immunologic features of that embryo itself. Because remember, the embryo is going to function almost like a little splinter that's going into your skin. It has to find a spot and it boop, it goes in. It does make that noise, by the way. Boop. It goes in and it really creates a little immune reaction. And we need that immune reaction because that's what causes what's known as the trophoblastic tissue to start to grow. And that's the part that's going to become the placenta. That's how that happens. And so it really, how it selects one individual space from another is not something that's really well understood, but it's thought to have something to do with the immune response between the endometrium, the uterine lining, and the embryo itself. So you wouldn't want to say, oh, I'm going to glue that embryo to this spot. I'm not going to try to force it to be in one specific place because we want it to go where nature wants it to go. And that's kind of how that process works. But I wish I had come up with that idea for the name embryo glue, because it does sound like the real thing, right? You've got to have glue, otherwise the embryo doesn't stick. But that was an excellent question. I am super glad that you asked it. Hello, Stephanie. Good evening. And hi to Amy Beth. Nice to see you folks here tonight. We've got PimDoc over here on this side as well. Got a bunch of people over on the Facebook and YouTube and LinkedIn sides, but doesn't tell me who you are. So throw me a name and say hello so that I can say hello back. If there's anything on your mind tonight about getting pregnant, about hormones, about women's health, this is the place that you can ask it. So I did have a question that came from Beatrice, and Beatrice asked, is there an age after which I am too old to have an embryo transfer? Okay, that's an excellent question. Well, so the first thing to know is that when you're using your own eggs, as we mature, it becomes harder and harder for us to be able to achieve a pregnancy, because those eggs, as we know, have been there since the day you were born. So sperm that comes from the guy today is manufactured in his body 3 months ago. But every single egg that a woman will ever have is there on the day of birth. And as we mature, we start to lose those eggs to the process of aging. And the DNA in those eggs starts to become less stable over time. And so unstable DNA means eggs aren't normal, means that they can't grow into normal babies in most cases. So if you're using your own eggs, once we're above about 43 years old, the prospects of successfully achieving a pregnancy through IVF become very, very, very low. Just being honest here, that the odds are really against you. Even at 41 and 42, it can be very hard because there's a big issue with egg quality. So, in our 40s, it is no longer about the timing of getting a sperm together with an egg in most cases. And so sometimes people will come in and they'll say, well, I'm 42 years old now, and I just, I want ovulation induction and we want to do timed intercourse. Rarely does that get you pregnant. Now, it could. You might get lucky, but if we're looking at statistics, if we're looking at what is going to be something that is going to be the greatest probability of success, timing of intercourse or timing of sperm getting together with egg is not the issue anymore. In our 40s, the biggest issue is getting an egg that's chromosomally normal, so that when a sperm comes along, it can fertilize it and create an embryo. Because most of the eggs at that point are no longer normal. So getting that normal egg is the more important feature than just the timing at which you release an egg and when the sperm's going to get there. Now, that's talking about success rates of fertility treatments in our 40s. But what you asked here, Beatrice, was is there an age at which it's too late for me to do an embryo transfer? Well, here's the thing. The uterus does not age at the same rate that the ovaries do. Those eggs are constantly maturing, but the uterus, you could be 50 years old and your uterus may think that you're 21. It doesn't know. Nobody told it. So hormones may start to be abnormal at that point because of what's going on in the ovaries. So you may have hormonal symptoms. You may have irregular bleeding. You may have other uterine issues, but we can stabilize all that because you can take an embryo theoretically at any age. The egg may not come from your ovary. In fact, if you're certainly over 44, probably, that's when we really kind of start thinking about using donor eggs, which we can do really at any point. But even trying with your own eggs becomes something that is just it's gonna be hard. It's a very, very tall obstacle, not completely insurmountable, but it takes a lot of time. It takes a lot of money, and frankly, and may just not work out with the outcome that we hope. So your uterus, however, can absolutely hold that pregnancy. Now, once we get a little bit older, so when you're over, let's say 45, we like to make sure that your OB doctor is okay with taking care of you because that becomes a higher risk pregnancy. Certainly, women who are over 50 or who are in the menopause, can you be pregnant? Yes, you absolutely can. Usually with a donor, an embryo that's created from a donor egg or a donor embryo. But of course, over 50, we're also talking about issues that really have changed in our own bodies, mostly in our circulatory system. So our hearts are not what they were when we were 20. Our vascular system is not what it was before. We may have other issues like cholesterol issues, hardening of the arteries. We may have hypertension. We may be more prone, we are more prone to things like diabetes and other kinds of things that happen to us as we mature. So in those situations, we want to make sure that the heart is going to be healthy enough. So usually we ask for a medical clearance at that point, that a cardiologist or an internist wants to tell you that you are healthy enough to be able to sustain that pregnancy. Certainly, in that scenario, we also are asking for your OB doctor to kind of give you a blessing and to say that they're willing to take care of you. Because one of the things that sometimes happens, unfortunately, in this day and age, is that medical liability, especially for OBs, that insurance is very, very, very high. It costs a lot of money. Why does it cost so much? Because even if everything is done right, sometimes bad things can happen. That having a baby is not a perfect process. It's something that we really worry about every day. But you can do everything right. Your doctor can do everything right. The hospital can do everything right, and there can still be a problem. Frankly, with the baby, things can happen, and so that's why. And oftentimes when they do, first thing people do is they want to go and sue the obstetrician. So some malpractice insurance policies will have age limits on the patients that the doc can take care of for that reason, because as we get to these higher risk type pregnancies, the liability is higher. So you want to make sure that your own doctor is comfortable taking care of you. Oftentimes there will be a consultation with a doctor known as the MFM, the maternal fetal medicine specialist, also known as a perinatologist, who can really talk to you about some of the specific risks that are associated with whatever the condition of the situation is that you have. If in this case, we're talking about being older. So Beatrice, yes, you absolutely can get pregnant in theory at any age. For women who are over 55, we have to really think carefully about it because there may be so many other risks involved that it outweighs any of the potential benefits of doing it. And you could potentially make that same argument over 50, but in our practice, we say 55. And the American Society for Reproductive Medicine says, up to 55 is worthy of a conversation, but understanding the risks that are involved. But the bottom line there, friend, is that the uterus ages at a different rate than the ovaries do. So the eggs will tire long before the uterus does. And that's kind of the way that works. Hey, Cowser, nice to see you here this evening. Haven't seen you around for a little bit. Folks, it's the top of the hour, and that means that we are going to be about out of time tonight. But let me just say, as always, it is a pleasure to be with you here at Fink and Friends every Tuesday evening at 5 o'clock Central Time, which means 6 on the East Coast, 4 in the mountains, and 3 on the West. This fertility thing is not the book of your life. This is just a chapter. And what are we doing? We are here to rewrite that chapter together. Every step forward with love, every step forward with kindness. Remember, try to do something nice for a stranger tomorrow. Change the world one day at a time, one mind at a time, and with one simple act of kindness at a time. And every day forward with hope. Because tomorrow, my friends, is a new day, and it is full of all new adventures. So, until next week, thanks so much for being here. I'm Dr. Randy Fink in Pensacola. Good night.